Hi everyone. This is not fancy schmancy like if Eric would have done it, but anyway, this will do. Get the point across. So I wanted to finish what lecture we didn't finish on Tuesday, just to make sure we kind of stay on track a little bit and you don't get behind. And I didn't want you to have to figure all this out on your own, so it's easier for me to just talk about it. You listen, take notes on your PowerPoint as we go along. So we're going to talk about inflammatory bowel disease, which is not to be confused with irritable bowel syndrome. So IBD versus IBS, don't get those confused because symptoms are not necessarily the same, nor is the treatment. IBD, don't really know what causes the inflammatory bowel disorders, and those disorders are ulcerative colitis and Crohn's. That's what makes up this condition. Don't really have a cure for it, and everything is just based on symptom management. Your patient presents with all kinds of complaints about diarrhea versus constipation. They're experiencing blood loss. They have volume depletion. Those are the things that we base diagnosis on, in addition to colonoscopy. But it's symptom management, symptom presentation, and that's how we treat our patients. So if you look on page 1272 in your book, there is a great chart of some things that you'll need to make note of that tells the difference between the two. Ulcerative colitis, your patients have about 10 to 20 stools a day, bloody stools. So you can assume that hemoglobin's going to be low, possibly anemic. They're going to be hypotensive. They're going to be at a risk for injury just based on volume depletion because, 10 to 20 stools a day, that is a lot, especially if you're experiencing blood loss with it every time. Crohn's disease, though, they only have 5 to 6 stools a day, non-bloody. Now, it sounds like, okay, Crohn's is the way to go if I'm going to have something, but usually with ulcerative colitis, there's no potential surgical complication as opposed to with Crohn's. With Crohn's, you get a lot of fistulas, and if you remember, we talked about paralytic ileus, your patient's at risk for that. They're at risk for a fistula where part of the bowel kind of strangles itself a little bit, loses some blood flow, volume, blood flow, stool, try to find some other means to get out. So they kind of migrate or gravitate towards weakened wall areas. Now, when that happens in Crohn's disease and they find these weakened wall areas, they create what we call like an outpouching, or kind of like a little balloon that sticks off of the bowel wall or the intestinal wall, and that's when we start developing our abdominal aortic aneurysms. So if I had to choose between the two, I'd rather have ulcerative colitis and stay in the bathroom all day as opposed to Crohn's and have the risk of a fistula turn AAA. Both of these have issues of volume depletion, hypotension, nutritional deficits because we lose vitamins, minerals, and things like that. Electrolyte depletion is always a concern with both. Both of them are diagnosed pretty young, and we misdiagnose it because we think young girls who have all these problems with diarrhea in their bowels, it's stress related or it's menstrual cycle related. So we kind of, just don't really pay a lot of attention to it the way that we should until they start having excessive bloody stool with the ulcerative colitis, or when they start having complications of like abdominal distension, excess gas, and volume loss with the Crohn's. Now I know that I'll be going back and forth between the PowerPoint and the book, but I do want you guys to follow along on your PowerPoint because that's really the only way to kind of keep up track. Now, for the next one, the description, it just kind of tells you where the ulcerative colitis starts and where the Crohn's disease starts as well. Both are an inflammatory process to where it can cause like a gastritis all the way through. Your patient can have some GI upset, bleeding, GI, upper or lower GI. Mostly, though, the bleeding is going to happen with the ulcerative colitis as opposed to the Crohn's. Now, if you look at the bottom, with the ulcerative colitis, your patient's bowel, very inflamed. Mucosa becomes very edematous. You have a lot of breaking of capillaries. The edema is coming from the inflammation, becomes very hyperemic, very, what am I trying to say? Very stressed, very tight. Just kind of like you keep filling a balloon, filling it, until eventually you start getting those marks on the balloon that show the weakened areas. That's what starts happening to your ulcerative colitis. That's why the bleeding occurs. You can get some tissue necrosis because of the bleeding, because of the edema and the pressure. And these patients are also at a risk for obstruction because anytime your patient has bleeding, natural response is for platelets to aggregate. And when platelets aggregate, they cause a disruption in flow, hopefully by creating a clot. So sometimes your patients will clot, and that will actually cause the obstruction. Now, some problems with ulcerative colitis have been tied back to patients with a history of C. diff. So just keep that in mind. We talked about C. diff. And let's look at page 1273. And let's talk about stool on our patients. Now, in table 60/4, we know complications of hemorrhage and perforation. We talked about that the other day. And, when patients perforate, you know it. There's really not a doubt in your mind. When they present to you with a suspected perforation, you can pretty much tell by looking at them, by listening to them, by noticing their restlessness, that a perforation has occurred. Now, they can get an abscess formation. They can get toxic megacolon, which megacolon means that the bowel is actually distended. It could actually torque and twist and cause necrosis. It could also herniate, and we could develop the outpouching as well. Malabsorption syndrome, that is a condition where we lose all essential vitamins, minerals, nutrients. We can't absorb them through the walls because if we have walls that are so inflamed, irritated, edematous, there's nothing going in. They're no longer permeable. So we lose a lot of those things that we need. We can have a complication of bowel obstruction, fistulas. And fistulas can lead to the AAA like we talked about. Ulcerative colitis can cause colorectal cancer. Now, they say that anyone over the age of 50 needs to have a colonoscopy every year to look for things such as polyps, dysplastic cells, hemorrhoids, and such, because our diet changes as we age, and, we don't probably eat as healthy as we need to. So we get a lot of hemorrhoids, constipation, things like that. We can also have, with ulcerative colitis and Crohn's, some other complications in other systems like liver, GI, biliary. We could have some ductal problems with biliary or bile flow. We could develop stones and such. And osteoporosis, very common with people with Crohn's disease. Now, if we look over here on our table 63, This is kind of like a staging system like we do for our oncology patients to tell exactly how bad the ulcerative colitis actually is. Mild, they have less than 4 stools a day, and it goes all the way up to fulminant, which is more caustic or toxic than severe, and it has a very poor prognosis when your patients reach a fulminant stage, whether it be in hepatic failure, which we'll talk about next semester, or heart failure, which is cardiomyopathy. When you reach this point, you're going to have to be very aggressive in your interventions as opposed to just diet control, replacing with oral iron. It's hard to say, iron. You're going to migrate to actual iron piggybacks or blood transfusions, factor replacement for clotting times and things like that when you get to this stage down here. Usually the factors that are deficient, and we'll talk a lot more about this next semester, but your clotting factor 7 and clotting factor 10 are ones that you will find missing most often on patients who have really severe ulcerative colitis. All right, now when we talk about Crohn's disease, Crohn's is more chronic with less acute complications. We don't bleed as bad. We don't have as many stools. We don't have near as severe volume depletion. But it can actually exacerbate itself and come and go based on triggers, kind of like asthma or kind of like any kind of inflammatory process. Now, it's usually diagnosed in adolescent, young adult age as well, just like our ulcerative colitis. And if we look down here at the bottom, our patients with Crohn's, we can tell by looking, this is not really nice and smooth. If you remember when we looked at the videos for an upper endo, and we were looking at the esophagus, and we compared it to the one with Barrett's, okay? If we looked at the normal esophagus, it was nice, smooth, pink, moist. That is what your lower GI tract should look like as well, with just minimal what we call rugae or striations, which kind of help the stool move out of the body. But otherwise, it should pretty much look like your esophagus. Well, this doesn't, okay? This is red, it's angry, we've got polyps. If you look here at these raised areas, those are polyps. Looks like we might have a little bit of bleeding. So this is a great medium for not only bacterial growth, but for dysplastic cells. Now, your patients with this, either condition really, we talked about that they can have malabsorption disorders, prone to obstructions, anemias, ulcers and strictures, because if you have these little polyps, and this is just inflammatory pockets, if you have these little polyps that get very angry and increase in size, you could actually cause, have a stricture to where you lose this part of your canal. Okay, so now something that was as round as a water hose or as open as a water hose is now half of that size. So you get a lot of, consequently, constipation. You get a lot of diarrhea seepage around stool that is hard and formed and won't come out. So strictures are not a good thing to have. Now, your patients, like I said, they're very prone to medium growth, bacterial infections, and seeping diarrhea around constipation. Now, it's not uncommon for when someone has Crohn's disease exacerbation to have a low-grade temp with it. Because usually with this exacerbation, they have an increase in metabolic rate, which is going to increase their temperature. Now, nonspecific complaints.